Dialysis was invented by physician Wilhelm Johann Kolff, who constructed the first artificial kidney in 1943. In 1946, Professor Nils Alwall modified it into the first truly practical device for hemodialysis. Some 70 years later, dialysis is essential for millions of patients around the world. The dialysis industry is in transformation. Initially, Medicare paid dialysis providers using the same fee-for-service cost-based reimbursement method used in the traditional Medicare program. Over time, fees and EPO costs escalated, and the CMS saw a need for change. The introduction of the Affordable Care Act also paved way for the re-engineering of the financial landscape for dialysis clinics to bundle reimbursement, as well as shared savings similar to accountable care organizations called ESCO. The question is how to adapt to the new financial landscape. The financial revolution of dialysis coincided with a technological revolution. The introduction of smartphones in 2007 resulted in a new world of opportunities for digital health. At the same time, the increased use of artificial intelligence has transformed many industries. Tasks like landing an aircraft to manage customized retail offers to sports reporting are fully automated with an uncanny precision. But what is artificial intelligence, and how does it work? Artificial intelligence is influenced by mathematics, biology, statistics, and computer science to build automated intelligent software replacing humans doing repetitive tasks. Often the calculations involved would take a skilled mathematician hundreds or thousands of years to perform. AI does it in minutes. Artificial intelligence can be compared to a production line in a factory. It takes a long time to engineer and build, but once up and running, it is a showcase of efficacy. Instead of pieces of raw material that make no sense going in and a Rolls Royce coming out, raw data goes in and a useful result, like a prediction or optimization, comes out. Engage Health IQ and Experlytics work exclusively with transforming care. We offer a holistic solution looking at many aspects of the patient on a personalized level. Every individual is unique and responds uniquely to treatment. Across the line, analytics and treatments are outdated in the new landscape. To break routine and combat key issues in end-stage renal disease, we go all in with our computational analytics. The mission is to decrease mortality, manage cardiovascular diseases, and optimize anemia drug administration. Also to tackle the notoriously difficult hospital readmissions and reducing length of stay. Finally, ensure QIP adherence. Some results will materialize immediately, but as results compound over time, we are in it for the long haul. Our artificial intelligence solutions are not expensive, but they do cost a lot. We have achieved 85% accuracy on mortality purely on admission data. Taking more sessions of data into account, we hit 90% plus. By identifying high-risk patients accurately, they can be managed separately. A few treatment and outcome cycles later, the system can predict future sequences of outcomes effectively. This will lead to preventative and prescriptive care unique for each patient. The more comorbidities, the more complexity. Due to the constraints of human analysis, evidence-based medicine has been like a 2D painting looking at, for instance, diabetes patients from two sides. A diabetic is rarely just that, so a two-sided approach is more of wishful thinking. With the computational power of artificial intelligence and the opportunity to personalize medicine, we can now upgrade to look far beyond two variables. Our tools routinely sift through thousands of variables for thousands of patients, finding connections between multiple variables, leading up to clusters of patients and areas of improvement. This helps you pinpoint care and treatment and provide systematic care where EPO and other drugs are aligned. Just adverse drug events are the largest contributor to hospital-related complications and account for more than 3.5 million physician office visits each year in the US. By analyzing thousands of variables, the notoriously difficult hospital readmissions can be predicted and thus prevented. Similar to high-risk patients, this group can be singled out and ranked out of their likelihood for readmission. We put this information up on a real-time dashboard. Permanent high-risk patients can be equipped with a mobile health monitoring device for high-resolution data, leading up to suggested lifestyle changes, coupled with coaching. The mobile health is also a sort of safety net where patients are discharged but stay on the radar. Empowered and enlightened healthcare professionals can therefore cut down on length of stay. To sum up, in an end-stage renal disease setting, we will precisely identify high-risk patients, accurately identify best practices, reduce hospital admissions and length of stay, optimize medication and operating costs, and increase care plan adherence.